up with something in order to make sure that our patients around the world who badly need rehabilitation services will be able to access it. I want to introduce myself once again. I'm Gerard Francisco. I am based in Houston, Texas, originally from Manila, Philippines, but Houston has been home for the last 3 years. And I'm so honored to be serving as your president for the next couple of years. Well, actually, only until six months and 2 weeks from now. I will be moderating today's panel with the help of our colleague Abderrazak Hajoui, because there will be other meetings that will happen after this. This is a session that was organized by the WHO, ISPRM, and the World Rehabilitation Alliance, or WRA, which is a WHO-hosted network of more than 130 or 103 organizations that are committed to advancing the cause of rehabilitation around the world. We have distinguished speakers this afternoon. We have representatives from the WHO itself, the WHO regional offices, country-level experts, and individuals with lived experience, and will help us explore the topic of why rehabilitation must be a core part of the universal health coverage considerations, be a part of the conversations regarding financial strategies and reforms in healthcare systems around the world. Our population is aging. I don't need to say that because we all know that. I feel that myself. But just for the purpose of statistics, in about another 25 years, in 2050, the number of people who are age 60 and over will double. So we are an aging population, and with aging comes many chronic health conditions that may require or will require rehabilitation. Many people are living longer because of the advancements in medical sciences, changes in people's lifestyles. Many of the risk factors to chronic health conditions have been diminished, so there are more older people who will live longer, but unfortunately, it's inevitable that chronic health conditions will coexist. Already, about 2.6 billion people worldwide live with a health condition that can benefit from rehabilitation. Those who are experiencing chronic diseases, chronic pain, impairment in mobility, sensory problems, and cognitive limitations. However, access to rehabilitation is so different, not just across countries, but sometimes even within countries. This problem is even magnified in low resource settings. And I don't know what's happening, but it seems like almost every week there is a natural calamity that's happening. There is an emergency that's happening in different countries around the world, and that all contribute to the already existing problem of disparity in access to rehabilitation. I should also mention, which I think I'm preaching to the choir, so to speak, because you are rehabilitation professionals, but I still would like to say that our field of rehabilitation is so important because it is one that will ensure that people will not only live long, but will live quality life. We support independence, participation, and productivity, so we should stop thinking of rehabilitation only as a clinical service or a clinical scientific field. Rehabilitation is actually a bridge that will help our countrymen and citizens around the world to be able to participate more in society, to be productive, and live dignified lives. Even though rehab is officially part of the essential universal health coverage, in theory, it is often missing from benefits packages. It seems like it's an afterthought. And I think the agenda that we have to push is that rehabilitation will have to be front and center. It has to have a seat at the table from the very start when discussions are being done in order to make decisions that will have an impact on universal healthcare coverage. As we look forward to the UN high-level meeting on universal health coverage that will happen in 2027, where heads of state will meet to discuss universal health coverage, we need to ensure that rehabilitation is fully integrated in the heart of the global and national commitments of universal health coverage. These are the objectives of this session. It's big, all-encompassing, but I promise you our speakers will do a terrific job to make sure that these are covered. So first, we will identify major gaps in how rehabilitation is currently integrated or not integrated into policies of universal health coverage, financing, and planning. Second, we will hear from regional and country-level experts on the realities of implementation. Third, we will focus on the lived experience. What does it mean for someone who is living through a condition that requires rehabilitation? What else do they need? And finally, looking forward, we will be discussing how we can better align our efforts across professional societies, global platforms, and national systems to push ahead the agenda of this meeting that will take place at the UN in 2027. Move to the presentations. This is my request to you. Our speakers have already prepared what they're going to say, but we would like this to be as interactive as possible. So to facilitate the discussion that will take place following the presentations, I would like you to reflect on these questions. What would it take to include rehabilitation in your particular country's universal health coverage benefits package? How, as rehab professionals, can we address the workforce shortages and ensure that rehab professionals are included in the metrics of universal health coverage? And finally, what are the most promising financial strategies to reduce out-of-pocket barriers for people around the world? I'm really honored to be able to introduce our speakers today, each one bringing a unique perspective to universal health coverage and rehabilitation. First up will be Anthony Duttini from the WHO. He brings a global insight on why rehabilitation remains the missing link in the delivery of universal health coverage. Solomia Kasianchuk from the WHO country office in Ukraine will share regional and financing perspectives, including lessons learned from Europe. Dr. Awad Mataria, the Director of Universal Health Coverage and Health Systems at the Eastern Mediterranean Regional Office of the WHO, will focus on topics regarding financial protection and the challenges of out-of-pocket rehabilitation costs. Dr. Younes Akhlal will join us as an advocate for those who have the lived experience and will speak on what universal health coverage, or the lack of it, means for families like his. And last but not the least, Dr. Abderrazak Hajoui will close with insights from the ISPRM and the WRA, offering key policy directions going forward. Without any further ado, I'd like to turn over the microphone to our colleague, Anthony Duttini, to give the first presentation on universal health coverage and why rehabilitation is the missing link.
Thank you and good afternoon, everybody. It's a great pleasure to be here. And hello to those of you joining online as well. I'm Anthony Duttini, the lead for rehabilitation at the WHO, and it's a great honor to kickstart this discussion about universal health coverage. As Gerard has just mentioned, the upcoming events in the global health calendar in the next couple of years, universal health coverage is coming front and center. And so this is a really important moment for rehabilitation to make sure that it is well captured within that bigger movement of universal health coverage. So we felt that to start off with, let's be in the same page as to what we mean by universal health coverage. We may all have different notions and considerations of what it is. So you'll indulge me for a moment. My presentation is the same slide several times over. So first of all, the universal health coverage, its definition from the WHO, it means that all people have access to the full range of quality health services that they need when and where they need them without financial hardship. And I'm going to break that down a little bit. So, first of all, this concept of access, coverage. Can people get the care that they need when and where they need them? It doesn't mean that all services are in hospitals, nor does it mean that all services are in primary healthcare. It means that the right coverage of services are available depending on what the population's health needs are. And when we're looking at rehabilitation, we've heard compelling evidence that 1 in 3 people in any given country has a health condition for which rehabilitation is beneficial. That's higher in some countries where it's almost 50% of people, lower in some countries, but a global average is 1 in 3. So people have need for these services. And yet then by and large for rehabilitation, not getting them where they need them, if at all, and when they need them, if at all. Often we hear cases around the world of people having to wait months and months and months before their first session of rehabilitation. I was in a country not too long ago where the average age of a child coming in with cerebral palsy to a rehab center for the first time was 6 years old. We hear stories of people only having access to rehabilitation after their stroke once they receive a certificate of being a person with a disability, and then triggers access to rehabilitation. People are not getting the services when they need them, and by and large, they're not getting it where they need them. So access is a crucial component. Is there good coverage of these services? Secondly, and I'm going to jump and we're going to hear from Solomia and Yunus, I think, later on about financial coverage. So I won't talk too much about that. But it's an essence of universal health coverage is that too many people fall into poverty because of a health crisis of them or a family member. It's a major trigger for people falling into poverty. And it doesn't necessarily mean universal health coverage that all services should be free. And that's often a misconception. It means that the right balance of insurance, of financial approaches should be there so that people are protected from falling into poverty or not being able to pay for services. And again, in the rehabilitation sector, I think we can all allude to the fact that often coverage isn't there. People have to pay significant amounts out of pocket for services. And again, I've seen cases of parents of children or of people having to choose between speech therapy and physiotherapy for their child, or between one service and another because they simply can't afford to pay for both. So universal health coverage has this financial protection component within it. Thirdly, it's about the range of quality health services that they need based on what a country's needs are. And I have good news for you on this point. The second part of the definition of universal health coverage is that those health services should cover the full continuum of essential health services from promotion to prevention, treatment, rehabilitation, and palliative care. Rehabilitation is defined in the very header of what universal coverage is and should be. And we should all take that home with us to say it is there in language, but is it there in reality? And the answer is unfortunately often not. The indicators that relate to measuring whether universal health coverage is being achieved do not yet refer to rehabilitation, whether that's it within workforce coverage. Rehabilitation workers are not counted at the moment, whether that's in financial protection or services. They're not there in terms of what's being measured, even though they're there in the headline that rehabilitation should be covered within universal health coverage. So for me, I think one of the things as I was thinking about what I would present and sort of think about doing in terms of where rehabilitation sits is we've looked at the different words within this, but there's a key word that I think is really important for us as a rehab sector to take, and that's the word universal. We need to start thinking about the narrative of rehabilitation as being universal. My son is 4 years old. He receives rehabilitation speech therapy for a lisp. I broke my hand playing rugby recently, and I had some hand therapy after that. My wife had postpartum therapy and pelvic floor therapy after her pregnancy. Everybody in this room and everybody will need rehabilitation at some point in their lives. It's universal. And yet we often tell the narrative in terms of rehabilitation being something exceptional, being for people with the most complex of injuries. And that's the way that rehabilitation is perceived at the moment. It's for the few, not for the many. It's not part of universal health. It's part of a system that when we can afford to catch up, rehabilitation can come as an afterthought. We need to start thinking of rehabilitation as a universal approach for the whole population that can benefit from child to older age, male, female, or any gender identity, really looking at the experience of rehabilitation being for the many and not for the few. And I think that's a really important component that we often miss when we're looking at access, health services, financial hardship, universality, and bringing that into your practices about rehabilitation being universal and needed by anybody at any time. 1 in 3 people is a really key message. So around the world, what do we see universal health coverage meaning, and where do we see rehabilitation coming into that? We unfortunately do often see it fragmented between different health services and systems, and even outside of the health service into social services and other. The work that we're doing in the WHO around Rehabilitation 2030 isn't trying to frame rehabilitation only as a service to be delivered within the health system, but as one to be led by the health sector that could be delivered inside health settings, but also outside of the health system as well, in schools, in community centres and other things. But very much the ethos of Rehabilitation 2030 is that the health sector and universal health coverage needs to take ownership back over rehabilitation, because people's functional outcomes are depending on it. And the place that people will be seen earliest for rehabilitative needs is likely to be in the health system. So it's absolutely crucial that rehabilitation in the next couple of years, as the growth of discussions around what's coming in the post-sustainable development goal agenda, post-2030, where does rehabilitation feature? And we need the voices of yourselves. We need the voices of those within the rehabilitation sector and those outside of it, working in other areas of medicine and health, to say rehabilitation is crucial for my population. Rehabilitation is an essential component of a health system, and without it, the population's health suffers. And this is the challenge that's set before us, because rehabilitation is misunderstood, misreferenced, it's used often in language but not in action, that we have a challenge for ourselves really as a community, and that's to get out into the global health community and start sending that message across. Rehab is here, it's universal, it's essential, and it needs to be covered. I think I'm going to leave it there for now, because I know there's a lot of presenters to come who are going to share a lot more in-depth information about that. But I think for now, I'm gonna leave it with that, and I'll move on to Solomea to talk about resilience and recovery, lessons from Ukraine for advancing universal health coverage. Is it okay, Gerard, or do you want to come and...
Hi, colleagues. Should I start?
Solomia, can you speak?
Yes, do you hear me?
Yes, we can hear you well. How does it sound in the back? Are you able to hear her? Good, thank you.
Great. Thank you very much, and thank you for the invitation to participate and to share experiences from Ukraine. It's a pleasure to join you today from Kyiv, and it's a pleasure to join also as a health financing officer. I think this is exactly where Anthony left off, that the community right now is very much centered around rehabilitation experts, and it's a pleasure to be to join your community as someone very much outside of that community, but learning over the last few years as we have embarked on this work in Ukraine to understand the importance of rehabilitation in the context of health systems and health financing, and what role it really plays in the system. We have had the opportunity in Ukraine to really leverage some of the challenges that we've experienced due to the war to really present rehabilitation as a key factor of the health system. So again, as Anthony mentioned, rehabilitation is also always seen more related to war trauma and complex patient needs. And this has been the in for us as we have been engaging and providing relevance for rehabilitation in the system, but this is only the first step This is only the in for us in Ukraine as we prioritize rehabilitation in the system, but there is a lot more that we've already started unfolding. So I would like to start a bit maybe with the next slide to explain the context in Ukraine of how rehabilitation has evolved, where we are now. Prior to, I would say, 2014, or historically speaking, rehabilitation in Ukraine has not been very advanced. We have had quite low quality services, things that probably you would not consider as really rehabilitation per se, more massage-based types of services. We have had poor workforce and no understanding in terms of regulations. What is rehabilitation? In 2014, when the conflict in Ukraine started, there was a increased need for rehabilitation for victims of war who started to actively need rehabilitation. And this was really the first time that it was brought to the attention of the government, the importance of rehabilitation. In 2014, also with changes in the government, new health system reforms emerged. And from 2017, we had a completely new health system reform, including the establishment of a national purchaser, the National Health Service of Ukraine. We defined our benefits package, and we had a number of service delivery reforms happening at the same time. At this time, as we launched all of these reforms, we always kept rehabilitation in all of these reforms. So when we developed service delivery, new models, etc., rehabilitation was part of that framing. A new law on rehabilitation in healthcare was established, and this was the first time that rehabilitation, as we define it, was introduced into Ukrainian health system normatively. And when Ukraine's national benefits package, the program of medical guarantees, was introduced, rehabilitation was considered as one of the packages, one of the core packages that was financed by the national purchaser, the National Health Service of Ukraine, under two packages of services, actually 3 packages of services. Hence already creating a space. So still quite limited workforce and quite limited capacities, but rehabilitation started to play a presence in the system and started to be scaled up. In 2022, with the full-scale invasion, the needs for rehabilitation increased drastically. And not only for conflict-related injuries, but also due to the war, we saw a lot more challenges with, for example, non-communicable diseases, which then led to increase in stroke and other related conditions which require quite intense rehabilitation care as well. Throughout the years, because of all of the increased need and the prioritization by the government, we actually see that from 2020 to 2025, we saw that the budget for rehabilitation tripled, going to about 4% of the budget of the benefits package, which is quite a significant change. Next slide, please. In this regard, with the budget increasing and the needs increasing significantly, the government reached out to us as WHO to provide them with guidance. How do we better organize services? How do we better finance services? So we have a group of colleagues in our office who work on the service delivery aspects with trainings and with workforce and service delivery models. And from my side and the health financing unit, we took on a completely new area for us, which was how do we improve financing of rehabilitation care? How do we find space for it in the benefits package, and how do we appropriately finance it? For that, we needed to understand 2 aspects. One is what is happening in the system in Ukraine? How is it currently being financed? What data do we have, and what can we understand from the system? And where do we want to go? And then for that second question, where do we want to go and how do we want to improve financing? We wanted to learn from other countries. So in the Ukraine office, we were able to commission a report from the European Observatory, where we gathered data with them from 14 European countries to understand how rehabilitation is organized and financed across these different countries, different health systems, to try and learn what we can from their experiences and how we can better improve our financing and our organization of care in Ukraine. And this has been quite important. And now we're at the stage where we already have all of these data. Both reports are published, and we are closely working with the National Health Service of Ukraine and the Ministry of Health to develop further financing of rehabilitation care. Next slide, please. And today I wanted to show just a few of some of the data that we saw. So I think what has been quite remarkable in the work that we have done is we do have a functioning e-health system with a wealth of e-health data that we can really see and start to understand who are we paying for, how much are we paying for them, how is the services being used, are our patients getting services in time, etc. So just to share a few slides, and you can read much more in our reports. For example, we were able to see that while the budget growth was increasing significantly, it wasn't necessarily increasing for those services that were a priority for the government. So, and we can always debate here, where is the best use of funds, because we do all have limited funds, especially in Ukraine in the context of war. For Ukraine, it would be our priority to really treat those who are in most severe patients. So we would have less funding available for lower back pain, but more for spinal cord injuries or patients after stroke, etc. And when we look at inpatient rehabilitation, we see that most of the patients are the more severe patients. They are mostly male, which are usually patients injured due to war, although we still have about 14% that have dorsopathy or arthropathy, so joint and spinal disorders, including arthritis, back pain, etc. So those categories, that's the yellow, those are still quite significant even in inpatient rehabilitation. And actually, when we look into the data, most of the hospitalizations are children to the age of 16, which is quite concerning but important to look into. While from the outpatient perspective, it's quite a different situation where these conditions are actually more than 50% of outpatient services. And here we actually see mostly elderly females who are receiving outpatient rehab and younger children, not so much adults. Next slide, please. We also look at if we are increasing how much we are spending on rehabilitation, and we can see who is receiving a rehabilitation. Our question is, who is not receiving rehabilitation, who could benefit? And if we just look at the very basics, for sure there are many cases where people can benefit from rehabilitation, but just even looking at patients, stroke patients or spinal cord injury patients, we can see in Ukraine that 78% of people after a stroke do not receive rehabilitation, and 80% after spinal cord injury have not received rehabilitation. This does not mean that they did not receive it at all, but this means that the government did not pay for it. So there is a chance that they might have gone to see private sector facility or some other means, but still this is quite shocking, where we see that the budget has increased, spending is increasing, prioritization, but still we have significant high unmet need, just looking at priority services, let alone for other diagnoses. Next slide, please. And what our availability of the data also allows us to actually look even further. So when we look into stroke patients, we want to know what kind of severity of the patient are we looking at, and how quickly did they receive rehabilitation after the stroke, because that will also depend on the impact that the rehabilitation will have on the patient. So we are able, right now, we have data using Rankin scale. Currently, we are implementing also BARFL scale into our eHealth system and soon following FIM as well, and working on some others as well. But we are already able to see between simpler cases and more complex patients who are getting into, who do not end up receiving rehabilitation, who have inpatient rehabilitation, who have outpatient rehabilitation. And we can even look at how much time between once they finish their stroke treatment and once they got into rehab. And these are some of the things that we are looking at as we are designing payment mechanisms for next year. Now we are introducing incentives to ensure that more patients receive rehabilitation in a timely manner after stroke. So we are taking it step by step to start introducing these incentives to really drive changes in the system and prioritize rehabilitation. Next slide, please. Another aspect that we analyzed in our report is looking at access to rehabilitation. This is also an important aspect. Ukraine is quite a large country, and access is quite variable. Definitely, there is variability in terms of access because of the war. So in this chart, you can see the most affected regions by war are red, increased vulnerability yellow, and less affected by war blue. So you can actually see, yes, for some of those most frontline regions, definitely access will be the lowest, but that's not necessarily the main factor of why access varies. So access varies for a number of reasons, and this is something that we need to look into the data more. We need to look into available workforce in terms of looking at patient pathways, etc., to try and work on this and make sure that there is equal access to rehabilitation. What we have also seen is that we have started to expand how many services we have of rehabilitation. So we have the number of providers has continued to grow year over year, but still we have very limited workforce, and you cannot open another department of rehabilitation if you do not actually have the experts, the professionals working and providing that service. And so this has been quite challenging, while even now it's becoming quite interesting and engaging for providers that they want to provide rehabilitation. It's very, very challenging in terms of having enough workforce to deliver care. Next slide, please. Very quickly, I know this slide is quite busy, but I wanted to show at least one slide from also the findings from the cross-European comparison. And this is, for me, I think the importance of this slide is just to show that if we look between 14 different countries, how they finance rehabilitation for inpatient daycare or primary care / outpatient rehabilitation care, there is no one model. It is very unique, and you need to develop a very unique approach to your country context. It is quite challenging, but you do need to understand and work with the data and think about what the incentives are, how ready your country is in terms of implementing one system over another. So if we look at global budgets or fee for services, so how flexible the system is, what we are trying to drive, more services or rather more containment. So there are different things to consider, but I think reading through the European cross-country comparison, you can find out some of the reasons why different countries have chosen different approaches and where some of the benefits or challenges lie between these. So I won't go into that today. Next slide, please. I wanted to highlight a little bit, a few reflections from the work that we have been doing, thinking about lessons learned and going forward. What are some of the things that we have learned in the work? So we have now been working on rehabilitation financing for about 2 years, working on these 2 reports. So I would say very much it's about strategic prioritization, defining who gets what type of rehabilitation and when. We know that there will never be enough budget to cover everybody, so we need to start identifying who do we start with, and then where do we start expanding and expanding and expanding. So we ideally want to cover everybody eventually, but we need to start with prioritization and seeing where can our systems feasibly, who can we cover, ensuring equitable and efficient resource use. Next is ensuring integration across the continuum, ensuring that PHC, specialized care, hospitals, community care, we have that entire continuum of care, because what we see in Ukraine is often patients fall out. They end up in inpatient rehab and then they never get to outpatient or community. They get lost. They do not connect with their primary healthcare doctors, and there is that lack of support. So this is an extremely important factor and something that also many countries that we've looked through the European experiences have been dealing with. Financing for outcomes. So this is also something about really also considering that there are different complexities of rehabilitation, and we need to adapt payment to address the different complexities. And so there is quite some nuance that we need to consider. And what we have seen, because we didn't have protocols in place and we're still developing it, financing has very much impacted how services are being provided. So you have to be very careful. What you pay for might be what you get. So if, for example, we had some set 14 days of rehabilitation, we ended up having most patients receiving 14 days of rehabilitation. And that was minimum number of days, not maximum. So you have to be very careful with what you're paying for and really addressing the complexities of different types of rehab and care and services needed. Data and accountability. Data is extremely critical in terms of driving transparency, quality, and prioritization. We need to get the data, we need to review the data, we need to work with the data monitor. This is what can drive reforms and can help position rehabilitation in the field. And engagement and governance. I think one thing where we have been most lucky and why rehabilitation has really been able to grow in Ukraine is that political prioritization. So about a month ago, we were able to present our report findings. And because of the importance of rehabilitation, not only from the health sector perspective, from the perspective of the economy and having people returning back to their communities, and understanding the investment that rehabilitation is for society. We had the deputy head of the Office of the President, the Minister of Health, the Minister of Veterans, the head of the National Health Service of Ukraine, and the head of the Parliament all join in the meeting because they understand the importance and how critical it is. So this is something that I think is important in every country to really get politicians involved. Next slide, please. And this is just pretty much a summary of the previous slide, but I think this is exactly, if we specifically reflect on UHC and thinking for low and middle income countries, we need to have that political commitment. If there is no political understanding what is rehabilitation and what it can do for the country, it will be a big challenge. So you need to think about it not only from the health perspective, but from the economics perspective, from the well-being of society, from the perspective of resilience of society and recovery. So this is extremely important. And also about the multi-sectoral collaboration. So Ministry of Health for us, Ministry of Veterans Affairs, Ministry of Social Policy, you have to connect all of these ministries. It's a complex challenge. If you start talking about assistive technologies, for example, for us, that is covered through the Ministry of Social Policy. Evidence-based design informed by data and international experience. There is starting to be more and more data available, more and more experiences. It's important to draw on those to design new systems and alignment with UHC frameworks, ensuring that rehabilitation is included in the benefits package, is budgeted for, and it's being monitored. And final slide, just conclusions. I know I'm already over time, so I will just wrap it up. Just wanting to say that really rehabilitation, it has been eye-opening for me as a health financing expert to understand the benefits that we can have from rehabilitation. Just next slide, please. The benefits that we can have from rehabilitation, and we really need to keep it at the core. When we think about country resilience and recovery, we need to be thinking about having rehabilitation at the heart of the system. It's not enough to just treat the patient in a hospital, etc. You need to get them to be a part of society. And for that, you need to ensure rehabilitation from the economics perspective. And it needs to be integrated into that UHC approach. It needs to be financed. It needs to have the person at the center. And we need to keep working with data to have better evidence and better understanding of the role of rehabilitation and how it can benefit the country. So data needs to be collected, needs to be monitored. And I think that that can very much drive further reforms in rehabilitation. Thank you.
Awad, are you online?
Yes, I am. I've
Okay.
been listening attentively and very much enjoyed the previous presentation. Can you hear me?
We can hear you, but your slide, he will control it? Okay, good.
Yeah.
Okay, there you go.
Wonderful. I have my slides shared from my end. So thank you very much, first of all, for this opportunity to be connected with you and to discuss some of the ideas related to rehabilitation again and in this round with regard to financial protection. So I very much enjoyed listening to the previous two speakers, Anthony and Sunomia, and I very much appreciate the linkage that was made between rehabilitation and universal health coverage. And as Sunomia was mentioning, she's coming from a health financing background. So just to introduce myself, so my name is Awad Mataria. I'm Director of Universal Health Coverage and Health Systems, working for the WHO Regional Office for the Eastern Mediterranean. And my background is indeed in health financing. So I have my PhD in health economics. So I will be building on what we have listened to, starting from universal health coverage and then digging deeper into the financing and in particular the financial protection agenda. So I'll start by sharing some updated information on where we find financial protection within that framework of universal health coverage. And then I'll share with you some updated data on where we stand with regard to financial protection globally, as well as in our region, the Eastern Mediterranean region that I'm serving. And then I'll try to make the linkage between rehabilitation and universal health coverage with a focus on financial protection. And I'll conclude with sharing with you some general information about the work that we are doing to support countries in transforming their health systems in the region. So I don't want to repeat what was said earlier, because the definition I have seen it in Anthony's presentation of what we mean by universal health coverage. However, what I would like to add is to say that if we look at universal health coverage from its definition, we can tease out three goals for universal health coverage. And this is where I would like to bring the discussion around universal health coverage and rehabilitation. The first goal of universal health coverage is to reduce the gap between utilization and need, which means that for people who are in need for a certain care, we would like to see them having access to that care. I think what Anthony has focused on the word universal is very, very pertinent. And that is where we would like to see that everyone who has a certain need is able to fulfill that need by accessing her or his needed health service, including people who are in need for rehabilitative services. The second goal from the definition is the quality of what is being provided, and the importance to guarantee that what is being provided is really contributing to the improvement of health and well-being of the individual. So not any service, but service of good quality. And last but not least, the third goal is related to financial protection, which means that we would like to see that people who are accessing care do not pay too much to the extent that they have to spend less on other essential services, to the extent that they might not eat well or will not send their children to school because they have to pay for the care that they need. And this applies very much for services that are of chronic nature, of long-term care, where people have to continue to pay certain amounts of money in order to receive them, that might push them into poverty or might make them face what we call financial hardship or catastrophic health spending. So financial protection is indeed one of the ultimate goals of universal health coverage. Now, if we believe in this and we have agreed that we want to achieve universal health coverage as per the different commitments, so where do we stand nowadays with regard to universal health coverage? Well, the situation is very, very grim. And globally, we are not doing well. This is the latest report that was published by WHO and the World Bank last year at the occasion of the second high-level meeting on universal health coverage that took place at UNGA, at the United Nations General Assembly. And what the report has shown that more than half of the world population, 57%, 4.5 billion people, do not have access to their needed health services. This is, of course, this is aggregate. We are talking about the entire world population and for all services. And amongst those who are having access, more than 2 billion, more than a quarter of the world population, face financial hardship when they go and demand their needed health services. And the situation has been really not improving over time. Even for the last 10 years, we are observing that the situation of service coverage has been stagnating, has not been improving, and the situation of financial protection has been deteriorating, going in the opposite direction. That's why financial protection has been given a lot of attention the last couple of years. For last year, the theme of the Universal Health Coverage Day was on financial protection. This year as well, on December 12th, when we mark the Universal Health Coverage Day, the theme will be on budget, on public financing, again, connecting that with financial protection. If I come to our region, so the Eastern Mediterranean region, and try to share with you some data based on the analysis that we are doing. So for our region, we estimate that almost two-thirds, 64% of the regional population, around 715 million people, do not have, this is the regional population, but two-thirds of them, around 507 million people, do not have access to their essential health services. And almost 1 in every 8 individuals face financial hardship when they go and demand and they are able to access their needed services. So 1 in every 8 individuals face financial hardship in our region. And the situation is even worse when it comes to the many countries in our region that are faced by some form of conflicts. And this is where we see that the population or the need, the demand for rehabilitative services is increasing. So if we take countries like Iraq, Syria, I'm just coming back from a mission in Syria last week, Sudan, Yemen, Afghanistan, as well as Palestine. Palestine is not on the screen because it's not part of the countries, it's not still a member state of WHO. This is where we see the need for rehabilitative services are the most. Yet, we find that the access to care in these countries is less than the regional average, and financial protection is even worse than the regional average. Now, if I want to take you further into the question of how we can change the situation, how we can ensure that rehabilitation is contributing to universal health coverage, that people in need have access and they are financially protected. So I will dwell on the two aspects of universal health coverage, the service coverage, the access, as well as the financial protection. And this is indeed coming from the definition of universal health coverage and from the target under the Sustainable Development Agenda, target 3.8. So if we look at the exact definition or the exact target 3.8, financial risk protection is put at the heart of it, beside the quality and the access to essential health services. So when we look at how we can help countries improve access to services, in the region, we have been very much inspired by the work done as part of the Disease Control Priorities Network. This is a huge project that started in 1993 as part of the World Development Report of the World Bank of 1993. And then repeatedly, there have been some revisions trying to define benefit packages under the umbrella of universal health coverage. The latest edition of the Disease Control Priorities published is DCP3, the 3rd edition. Now there is work on the 4th edition that is almost in the final stages. Part of it has been published, but the 3rd edition has really provided a lot of insights on how to help countries define benefit packages for universal health coverage. The Disease Control Priorities has come up with 9 volumes, looking at different aspects of services that are being provided, including volume number 9, that is related to injury prevention and environmental health. When I try to look and identify what interventions have been found to be cost-effective, have been found to be of evidence on their efficacy, on their effectiveness, and needs to be included in benefit packages, I found that there are a set of interventions that I will just list them for you. but those have been identified based on different criteria. Part of these criteria refer to the then or evidence on the effectiveness of the intervention, but also on the impact on the financial protection. The DCP3 has come up indeed with the three sorts of packages. A package that is referred to as essential universal health coverage package. That is a combination of interventions from the different volume. If I want to give you more details, it is around 218 interventions that have been put together. And then a subset of that essential universal health coverage package, which is referred to as highest priority package, that have been defined based on more stringent criteria. And then interventions that are not part of the health sector, but belong to other sectors, which is very much relevant to the agenda of rehabilitation. These are interventions that are related to environmental risk factors, but also behavioral factors that are done by other sectors other than health. We call them fiscal and intersectoral policies, and there have been a definition of around 108 interventions as part of that package. So I tried to look at exactly what are those interventions that are related to rehabilitation. So Chapter 15 in DCB3 has focused on rehabilitation as part of as part of the continuum of care, and has identified a set of interventions. I will not treat them in full details, but I'm leaving the slides with you, and has even identified at which platform, whether at community level, whether at primary care level, or at hospital level, such interventions would be provided. Some of these interventions are related to musculoskeletal system, others are related to cardiorespiratory system. There are interventions related to neurological services, and others that are more of assisted technology, the assisted product. So those have been identified and have been listed, and we have been using them in the region in helping countries defining their benefit packages. So we are trying to take universal health coverage from being a concept to translate it into a concrete interventions that are implemented. If I take the second dimension, which is the financial protection dimension, so countries have been using different modalities in order to shape their health financing system. Some countries rely mainly on their general government revenue. This is the money that is coming to the government from taxes, but also from natural resources in some countries. And part of that money is allocated through budgetary allocation mechanism towards health. Other countries have been using mechanisms or policies like social health insurance, where we have a fund that is separate from the government budget, and there are some earmarked contributions, payroll taxes that are deducted and going to that fund, and then that money is allocated to the health sector. And then there are other modalities like private health insurance, community-based health insurance. One is being for profit, and the other one being non-for-profit. So what is happening is that different countries have been using different modalities for shaping their health finance system to guarantee the access to the needed services, including the rehabilitative services. Just before concluding, I would like to share with you what we do in the region in order to transform the health system to advance this agenda of universal health coverage, but also, as it has been touched upon by the previous two speakers, also to bring in the agenda of health security, which is the health security, the resilience in the health system. In our work in the region, we had identified 7 regional priorities that we are working on, and that have been really taken very seriously by many countries in shaping their health system. The first one is the agenda of investing in health emergency and disaster risk management. We are looking at this as the foundation of the health system. Building health security is what you would need to do if you do nothing in the health system. So this is your step 0 in building your health system, investing in the essential public health function to guarantee health security. The second regional priority is building institutions. And we even say that we need to start by rebuilding, reorienting, optimizing ministries of health to be ones of the 21st century, or ones with the living institution following COVID, with all the learning that we have been gaining. The third regional priority is to shape the model of care. And I have listened to Salomia earlier referring to the primary healthcare approach and shaping the way that we are organizing and managing service delivery. The fourth regional priority for us is health workforce, is to invest in health workers, to protect the health workers in order to deliver on the needed services. And this has become one of the flagship initiatives of our regional director that I will touch upon very briefly. The fifth regional priority is the financial protection agenda. We as a region, again, we are not investing enough. We represent almost 10% of the world population. We spend less than 2% of what the world is spending on health. That's why we have identified this as one of our regional priorities. The sixth regional priority is to improve access to medical products, including medicines, vaccines, medical devices, and assistive technology, and other commodities. The seventh and last regional priority is to ensure the integration, to work on all of these priorities at the same time in an integrated manner, and to ensure coordination across the different stakeholders. This is my last slide. Just to mention that we have got endorsed by our regional committee, our ministerial governing body, a regional strategic operational plan for the next 4 years. And in this regional strategic operational plan, regional priority number 2 is related to ensuring access to quality healthcare for all. Again, the idea of all is very prominent, but also with a specification, especially for hard to reach and most vulnerable population. And I believe the population whom we are targeting fall under the category of the most vulnerable. Under this regional priority, we are working on, as an area of focus, on integrating rehabilitation and assistive technology into the national health systems of all the countries. As part of our regional strategic operational plan, we have identified 3 flagship initiatives that we look at them as accelerators to ensure the implementation of the regional strategy, including access. So we look at access to medical products, medicines, vaccines, assistive technology, and other commodities. We look at investing in resilient health workforce. And the third regional priority is very particular because we have observed it being needed in many countries, is improving access to substance use and to address the public health threat related to this. So I'll leave it here. I'm very happy to be also part of this discussion and looking forward to more collaboration. Thank you very much.
Dr. Awad, thank you so much. And just a clarification, if you're not familiar with the WHO regions, Dr. Awad represents as part of the regional office in Eastern Mediterranean, but that actually includes the Middle East and Northern Africa. So just to put things, his presentation in perspective. And speaking of perspective, I'm happy that our next speaker will provide another point of view, this time for someone who has a lived experience and how the gaps involving the universal healthcare has an impact on the people with lived experience. So our next speaker is Yunus Ahlal. Let's have slides. Nice to meet you, everyone.
Good afternoon, everyone. Thank you so much for this invitation. I'm waiting for the other microphone so I can just sort of bit walk around and talk directly to people. Yeah. It's an honor to be here. Do you hear me? Is it? Yeah. Yes. My name is Yunus Ahlal. I'm a urologist, robotic surgeon. I used to work in a university hospital in Nice in France, and now I'm working in like part-time, but 80% of the time in Morocco, and it's linked to my family history with rehabilitation actually. So today I'm not going to be talking to you as a doctor, but as a son of a patient who had a brain stroke in Morocco a couple of years ago. And thank you so much for listening to me, because it's I'm a doctor, and even though I'm a doctor and we don't have any we're coming from a privileged background with my brothers. My father is a doctor, my mother is the doctor as well, and even though we didn't have this kind of financial difficulties, we faced a lot of issues here dealing with this problem. So everything started on the 29th of September I'm going to admit everyone, so it's gonna stop popping up. It started on the 29th of September 2020. I'm a urologist. I'm used to like doing renal transplantation, organ harvesting. So when my father called me and told me that your mother had cerebral stroke, and he sent me the CT scan, I'm like, I lost my mother. So I took the first flight to Morocco, and I found out that my mother had a surgery, and this is also something interesting because my father is a neurosurgeon, and he tried to call her at 6 in the morning to because they used to pray together in the morning, and she was unconscious. So he took her to the ER. She had a CT scan. She had a CT scan, and we discovered that she had this kind of stroke. She had a surgery to remove this hematoma. And what I can tell you, the first issue, the most bothersome issue, is the lack of information, the lack of guidance. I'm a doctor. I wasn't even aware that there is a specialty, there is a medical specialty of rehabilitation. So when we went there, she was in the ICU, and and we didn't have any information. So after 3 days post-op, we were waiting for her to wake up and to stand up and behave like nothing happened. So that was the first issue. شكرا. You can't hear me. Okay, it's fine. I'm just gonna use this one. It's fine. So I continue. Okay, I can use but here from here. All right. So we were. I remember I was, because I had 3 brothers, and they all like having their lives abroad, and they all came in, and we were all standing, waiting for her to wake up. And this is crazy because we didn't have any information. We were surrounded by doctors, by anesthesiologists, by ICU doctors, etc. And we were standing there, and she didn't wake up. So like, what's going on? So I had to call one of my colleagues in France. He's a neurovascular surgeon, and just to get this simple information saying that it's going to take time. It's going to take time, and it will take maybe a couple of weeks just for her to open her eyes, maybe 1 extra week to be able to make her breathe without assistance, etc., etc. And maybe after a couple of months, she's going to wake up, and this whole process is going to take some time. So just to make the story short, I know I have 5 minutes more, but the thing is, after she got out of the ICU, which is not really covered by the insurance, maybe 30% is covered by the insurance. She stayed in the ICU in a coma for more than 30 days, and we had like 2 nurses for 15 patients. And we were there watching her. I was there with my father, who is a neurosurgeon, watching her. And that was crucial to make her live, actually, because she had some complications. She had some brain edema that needed some specific treatments, etc. So that was really tough. And when she left the hospital, they were like, all right, take her somewhere. When are you taking her home? I'm like, she doesn't move, she doesn't stand up, she doesn't speak, she has a tube. Okay, how can we take her home? And the other thing that we are lucky, we have a private hospital in Meknes. It's a city in Morocco, and we were able to manage a room with nurses, with staff, etc., to be able to give her some decent care. And then I remember that one of my very good friends is Professor Hajiwi. We went to med school together, and then we kind of split for different paths. And I called him, and he told me, you cannot do like that. You need the whole team to take care of your mother. You need speech therapists. You need the occupational therapists. You need proper physiotherapists. You need equipment, etc. So then I started to realize that, yes, this is going to take some time. This is going to be costly. And then when we we were able to take her home. We managed to get kind of a small rehabilitation center at home, having physiotherapists coming to see her, having speech therapists coming to see her, having occupational therapists traveling from another city, because it's not very popular here in Morocco, to take care of her. And so, like, the important to us, first to us, are the medical staff, like, coming to see her at home. She's now after 5 years, she's still dependent on people. She cannot do anything by herself. She's fully conscious. We thank God for that. We can communicate and everything. We can travel together, but she needs 24/7 assistance. So, and this is really costly. And the other thing, we realized that there are some medications, there are some care that is not available in Morocco. So we had to travel abroad. Like, for example, traveling to Miami to get the intensive physical therapy in an high intensity physical therapy center, which is really good because you can see progress day after day. And we did not want to make her miss an opportunity to get better. And this whole thing is really costly. In 3 years, it costs something like 2 million dirhams, which is something like 250,000 euros that we had to pay out of our pocket. This is just the basic stuff. I'm not taking into account all the flight tickets, all the hotels and everything, but it's really costly. And we are lucky to be able to do that. The problem in Morocco, look at the minimum wage. It's 3,000 dirhams. It's 300 euros per month. The median salary is 400 euros. You cannot do anything for your patients if you have this kind of income. So it's really important to look at this problematic and to make sure that these challenges that Morocco could overcome these kind of challenges. This is just out of my reflections. There is a lack of clear long-term guidance. Nobody told us or told the family members, all right, you're going to have to deal with this problem for many years. For me, you know what I took? I took 3 days off. I took I thought that would be enough for me to come to Morocco, take care of this brain stroke, and then she will be all right, and then come back to France. It didn't take that. For the first phase, it took me something like 2 months just to be able to watch her in the ICU. So we like information in Morocco. I just started. I just wanted to check whether the number to call if in case we have a brain stroke. It's very difficult to find. Let's say I have a brain stroke here in Marrakesh. Which number should I call? It's not very clear. And there is still a limited availability of advanced rehab centers. There are some centers that are kind of advancing. They're kind of building this kind of rehabilitation center, but it's still insufficient. The professionals are not very well trained. Physical therapists, speech therapists, we had to train them, actually. I used to go to France I took some internships in rehabilitation centers, and I used to train them. And of course, there is insurance coverage. The insurance coverage is not enough. In Morocco, we could do some really interesting stuff in other fields, in robotic surgery, in telesurgery, we are leaders, and it's all linked to the insurance coverage. So if we want to move forward with this problematic, we need to work on the insurance coverage, actually. And of course, there's this part that maybe not many people talk about, is the high financial and emotional burden shifted to the families because of that. And I think this is very important. And so that was my final slide. I would like to really thank you. And this is really important. In our meetings, we never invite patients, families, to talk about their experiences. And I hope this is useful for you guys to just understand what we're going through when we have this kind of problem. Thank you.
This one? Okay. It's not the screen. That one.
View.
There it is. I'm taking over the moderation of the session because Dr. Francisco had to move on to a session. Absolute pleasure to invite a colleague from the World Rehabilitation Alliance and our generous host here in Morocco as well, Professor Abderrazak Hajwi, to give some closing and thinking about the way forward from what we've learned today about universal health coverage. What does that mean for physiatry and physical rehabilitation medicine for the World Rehabilitation Alliance, and what's the way forward from here? Over to you, Abderrazak.
Thank you. First of all, I would like to thank all the organizing and the speakers of this session. It was very hard to plan this session at the last minutes, but with the help of the organizing committee, we are here now, and also with the involvement of the speakers and coordinators. So I will try to talk a little bit about charting the way forward and policy priorities for ISPRM and the World Rehabilitation Alliance. So I don't have any conflicts of interest regarding this topic. And during my presentation, I will highlight the role of rehabilitation in achieving the universal health coverage. I will identify the ISPRM and World Rehabilitation Alliance strategic priorities in advancing rehabilitation integration into health system and universal health coverage, and promotes professional engagement, advocacy, research, and partnerships to strengthen the rehabilitation workforce and policy implementation. So I will start by the definition that you already say. And I try to make the link with the rehabilitation workforce and this definition. So to have a quality health services, we need a high quality workforce in the health system. And where you listen to the story of our colleague Yunus, and sometimes we need to start rehabilitation early, and we can't find any facilities and good quality of workforce. And you can see here the rehabilitation is one of the core components of universal health coverage, with health promotion, with prevention, diagnosis, treatment, and palliative care. So if I ask you, in terms of percentage, for example, the budget of the cost of health care for example, heart failure, which percentage we can give to this part of universal health coverage, in your opinion? Which percentage? I need to help you with 1%, 6%.
Rehabilitation or palliative?
No, rehabilitation. Which percentage of healthcare cost can we put for rehabilitation? 6. More than 50. Great. So we can say this publication from 8 hospitals in Berlin about healthcare costs and universal health coverage. And you can see the total healthcare costs here. So hospital costs 69%, outpatient costs 11, medication 8, transports 4, costs of home nursing 3, cost of therapeutic appliance, 2, cost of healthcare products, 1, and cost of rehabilitation, 1%. So when we talk about money and rehabilitation, it's not really a big problem. And the real problem is it's about the awareness about the place of rehabilitation and the role of rehabilitation in the management of health conditions. In the same publication, you can say the absolute annual health cost, care cost. So you can say the total health care here and rehabilitation cost here, independently of the severity of the disease. So what is the role of rehabilitation doctors? Rehabilitation doctor should lead the change. He acts as a clinical advocate for the value of rehabilitation in every health system. And this is what we are doing every day in our clinical practice. Engage in policy dialogue, bring data, research, evidence, and patient stories to the policymakers, and advanced research and innovation in rehabilitation, generate local data, contribute to global evidence and inform practice and policy, join global network like ISPRM, like World Rehabilitation Alliance, to amplify collective impacts and contribute to shared learning, lead training, mentorship, and community-based rehabilitation initiative to strengthen local capacity and build a bridge between hospitals, academia, and policy for an integrated rehabilitation ecosystem. So at the end, I can say that every PRM doctor is not only clinician, but also researcher, policy actor, and change maker. And this is one of the most important things that we need to include in our curriculum program for the residency program. So in this slide, I try with my colleague Francisca to link the contributions of the World Rehabilitation Alliance with the contributions of the ISPRM. So we find that first contribution So first contribution is first. Can you hear me? No. Both. Okay. So first contribution of the W. Don't be. I can turn off this one. Okay, like that. It's good. Great. So first contribution of the World Rehabilitation Alliance, that is WHO Global Advocacy Network of more than 100 stakeholders supporting the implementation of Rehabilitation 2030. What is the ISPRM contribution for these aspects? It translates, produce data, translate scientific evidence to the policy. Second contribution of the World Rehabilitation Alliance promotes rehabilitation as an essential health service within universal health coverage. And the role of ISPRM is to promote capacity to demonstrate rehabilitation's cost effectiveness and translate evidence into actionable policy recommendations. Third contribution of the World Rehabilitation Alliance, strengthening the rehabilitation workforce and build policy capacity. And ISPRM can promote capacity building and leadership in physical rehabilitation medicine worldwide. And we have the ISPRM Academy for Capacity Building. Fourth contribution, support research and evidence generation for policy and practice. And ISPRM can support regional engagements connecting local reality to global strategies. And the last contribution, integrate rehabilitation into emergency preparedness and response. And ISPRM can strengthen emergency rehabilitation teams. And we have many examples during the earthquake in Morocco, in Turkey, in Philippines, etc. And I can show you here one example of collaboration between ISPRM presenting this position policy paper on behalf of the World Rehabilitation Alliance during the World Health Assembly in February 2025, highlighting the necessity to strengthen rehabilitation and universal health coverage. So this is an example of amplifying the global voice of rehabilitation within the global health agenda. This is another opportunity to collaborate with the World Rehabilitation Alliance as ISPRM to celebrate the Universal Health Coverage Day in December 12. The theme of this year is Health for All, delivering on the promise. And it's a great opportunity to advocate for improve and strengthen the place of rehabilitation at the heart of global universal health coverage discussions ahead of the 2027 United Nations high-level meeting. We have also another opportunity. It's celebration of the World Health Day in April 7. The team under the team Global Action for Universal Health Coverage and Health Beginning a Hopeful Future. So this the focus this year will emphasize the need to provide equitable and affordable access to healthcare for all. It will also specifically highlight the health of women and newborns. So we have this great opportunity to highlight the need of including rehabilitation as part of health coverage. So I can summarize in this slide the charting the way forward from policy to action. We need to integrate rehabilitation into global and national universal health coverage and primary care strategies. We need to invest in workforce development, training, recognizing incentive, and we say how the high quality workforce impacts the recovery and the well-being of the patients, promotes data and digital system for monitoring functioning, fosters South-South and intersectorial collaboration, and leverage global partnership with World Rehabilitation Alliance, ISPRM, WHO for the implementation of all these strategies. And I say that if we need to advocate for universal health coverage and rehabilitation, we need to start by education. We need to improve the quality of our education in the medical school or in the health science universities in general to advocate with education with all the health professionals, not only with rehabilitation professionals, before going to the lobbying. So I can conclude my presentation by saying that without data, you are just another person with an opinion. We need to provide more data, especially in low and middle income countries, about universal health coverage, about rehabilitation, about the gap and policies, how to can implement these strategies. So rehabilitation is a right, not a privilege. Together, ISPRM and World Rehabilitation Alliance, we are charting the path from policy to practice. Let's continue to build the future where every person everywhere can access quality rehabilitation services. And I can say together we can go further by joining forces for shared developments. Thank you so much for your attention.
Thank you, Abdurazak. Yeah, I've got the difficult wrapping up time because another session is coming. Without data, you're just another person with an opinion. That's my take home. That's a brilliant, brilliant phrase. Is there one burning question? And whilst anybody may have a question, I really, really want to thank Yuna and Miriam for really helping today setting up. And of course, Valentina and Amy, who are online, who are really instrumental in pulling this together from the World Rehabilitation Alliance. Any urgent burning questions that you want to clarify? We're going to be around afterwards as well to speak. I want to thank all of the presenters, those who joined us online, as well as those in person. Really fantastic to have a personal testimony as well. You are a unicorn in that you're a doctor that's not working in the rehabilitation field who can advocate, and you've got lived experience as well. So we're going to hold on to you as a really powerful advocate for the rehabilitation story. So thank you for sharing, and best wishes to your mother and the family as well. Nobody's raising their hand in urgency, which I hope means that you've had all of the information that you require to now go forwards and push the charge for rehabilitation and universal health coverage. So thank you very much for joining. We'll be around afterwards. Thank you to everybody again, and let's keep going through to 2027. Yeah. You want to come for the photo?
Yes.